Good afternoon to all of you. Welcome to the Hoya Innovation Experience Deferred Live Surgery session. I'd like to invite the chairpersons, Dr. Maipal Sachdev sir, Dr. Haldipurkar sir, please come on stage, as well as the panelists, Dr. Mohan Rajan sir, Dr. Naren Shetty sir, and Dr. Sudhir Srivastava. So welcome to this Hoya Deferred Live Surgery session. So we have a host of talks as well. We have the multi-cert injector system, the pairing approach, the rotational stability, the intermediate vision benefit, as well as a wide range of focus talks. And we have these 5 talks and a lot of panel discussion also. So we begin right away with the first talk. I'm sorry to say, but I would be jumping the queue and starting with the first talk, as I have another session as an urgency in the other hall. Dr. Haldipurkar sir was right here, I think. Yeah, he'll come. Can I have the slides, please? Yeah, thank you. So thank you, Hoya, for this session. And we begin with the first talk, and this is going to be basically about the pairing approach to achieve maximum spectacle freedom. So when we talk about trifocals or multifocal IOLs, today we have a lot of choice. And in order to get the best visual outcomes and to get happy patients, I think most importantly, we need to select the right patient. And all of us know that patients who are motivated, who want spectacle independence, more flexible, having the right mindset are better patients compared to those who are very finicky and very fussy. Definitely you need to select the right IOL. Today we have IOLs right from advanced monofocals to the ADOFs, to using micromonovision, as well as these trifocals. So using the best lens for your right kind of patient. You need to talk to your patient regarding his functional activities, the distance at which he needs his work done, as well as his daily routine, so as to select the best lens for him. You need to counsel the patient so well. You have to give him the enough chair time so that these patients understand what they are in for. And of course, we have the precise biometry and the surgery for these patients. So in our center, what we believe is having a perfect biometry, which is done with the optical biometry, as well as we use the immersion mode wherever the optical biometry is not possible. In all our premium cases, whether it's the torics or the multifocals, we use repeat readings. We recheck the readings and ensure that all these readings are taken before the eye is touched, even before dilatation and definitely before applanation. Each of these patients undergoes a proper ocular surface assessment, including management of MGD if at all present, a topography in all these patients, in those where you are planning a toric because you want to rule out any kind of irregular astigmatism or any kind of keratoconus which can cause higher order aberrations and an unhappy patient. OCT macula to rule out any kind of very fine irregularities like an ERM or a very fine lamellar macular hole which can be easily missed on even an indirect, especially if you have a dense hard cataract. A pupillometry and an angle alpha to rule out any high angle alpha, especially in high hyperopic patients where it can cause more risks of glare and halos. If you have a patient who have astigmatism, all these patients, you don't have a threshold like say 1 diopter or 0.75 diopters. What we do is we just put the K1, K2 onto the Barrett toric calculator or the Verion if you have, and you see whether the patient needs a toric or not. And we have definitely a very high threshold for the very low threshold for this and a high rate of toric use, especially the low power torics. Definitely discuss these options of either the toric multifocal depending on whether the patient affords it or the other options available. So now going on with my patient. So this was a patient who you can see the pupil is not very well dilated, but we are using a trifocal toric for this patient. So the axis is at 140. We have made 2 side ports and the main incision, put in viscoelastic. And when you have a not very dilated pupil like this, you need to be very careful. You don't want the pupil to come down, and you need to make the rhexis very, very carefully and going just parallel to the pupillary margin. sometimes just beyond it, and sometimes you can just go parallel to it. A very gentle hydrodissection. At this point of time, sometimes the pupil can come even more down, so you need to be careful. Definitely use of Phenokin Plus can help in causing more dilatation and as well as viscodilatation. So before even starting the phaco, I use usually a dispersive viscoelastic, a combination of sodium hyaluronate and chondroitin sulfate. You can either do a direct chop or a stop and chop in these patients. Here I'm using the stop and chop with the central trench, and then you make the central crack. It's very important to be in the central safe zone. As you can see, now we are making the smaller nuclear fragments and pulling with the left hand with the Sinskey hook. I'm just rotating it in the anti-clockwise direction so as to make the fragments. You can see the pupil is now slightly coming down, but yes, if you are in the central safe zone, and you can see the right hand is more or less steady, and it's the left hand which is bringing all the fragments towards the tip of the phaco probe. You need to have a very steady anterior chamber with very minimal fluctuations. So here I'm using the signature probe with the peristaltic and the case mode so as to have a very stable anterior chamber. Each of these nuclear fragments are then emulsified very gently. And there is a very thin epinuclear sheet here which also is then emulsified. For the irrigation and aspiration, I put in Phenokin Plus again to see what maximum dilatation we can get. If probably the pupil was even smaller, then I would have probably used a B-hex in this case. So a bimanual helps to give very, very good control over all the 360 degrees irrigation and aspiration of the cortex. And when you have a semi-dilated pupil like this, it's very important to be careful not to pull on the pupillary edge, because otherwise it will not only distort the pupil, it will cause further pupillary constriction. So sometimes you use the polish mode, and you can go even underneath the iris and underneath the anterior capsule, tease the cortex a little bit, and you can then bring out most of the cortex. So this is the geometric trifocal toric lens. We're putting in viscoelastic, and here you can see the tip of the nozzle that goes into the wound, and it's a very, very smooth delivery, and it goes into the capsular bag. So the pupil is still down, and you can see that even the marks are not seen. In such cases, you can just go in with a push-pull or with a V, and you can see where the marks are, and then you can easily, now you can see we have the Varion overlay, and we need to now rotate the lens to the desired axis, which is almost 90 degrees. So, but before that, we go with the irrigation port underneath the optic to wash off the viscoelastic. This is a very important step, because retained viscoelastic is one of the most common reasons why a toric IOL would rotate. And even otherwise, with the Hoya Vivinex material, it has the sandblasted haptic edges as well as the optic edge, and which gives a better rotational stability. And now we have the IOL aligned. We also have some patients who have given their feedback on this. Obviously, another patient, as this was the
घरी टीव्ही म्हणा, मोबाईल म्हणा, घरचे कामं करताना म्हणा आणि वाचन करताना म्हणा, खूप मला स्पष्ट दिसायला लागलं. हे तुम्हाला मी वाचून दाखवते बघा.
So she's speaking in Marathi, but the translation is there, and she's able to read very clearly. These patients are truly happy for distance, intermediate as well as near. So basically what we need is the pairing approach. So what exactly we mean by the pairing approach is the geometric family consists of the geometric and the geometric plus. So the geometric gives almost 50% at distance, so that gives you a very good vision at distance, 17% for intermediate and around 21.8 for near. But if you look at the geometric plus and you look at the second order, that is for near, it's almost 38.6, that is double of the geometric. So that means the increased light distribution for near gives you a very, very good, excellent near vision for these patients, especially if the light is also less. So this is a very important slide, and if you look at the defocus curves, with the pairing approach, so you can see that there are 3 pairs that are shown. One is the geometric in both eyes, the second is geometric plus in both eyes, and the third is the geometric in one eye and geometric plus in the other eye, which is the black line in bold. So here you can see that there is a tall peak for the distance and a very tall peak for the near also. So if you have put a geometric in one eye, the patients are usually happy for distance, intermediate as well as for near. But if you want to give them even better vision and even better clarity for near, then you put the geometric plus in the other eye, so they get the best of both the worlds. So here we get excellent results. So we have been using the Vivinix platform with the monofocals, with the torics, and now with the geometric. So it's not just about the ease of implantation, it's the preloaded advantage as well as the Vivinix technology with minimum of PCO, minimum of rotation, and definitely patient satisfaction, not only because of spectacle freedom but minimal of dysphotopsia, and all this helps us to give good visual outcomes and boosts our confidence. So to conclude, promising new technologies helps us to give better visual outcomes to our patients, resulting in happier patients. Thank you so much for your kind attention.
Hello. It gives me great pleasure to bring in the next player. That's none other than Dr. Rohit Om Prakash. He would be speaking on multi-set injector system, a surgeon delight.
Yeah, absolutely.
Over to you.
Thank you, sir. So I would be taking up this enhanced monofocal from Hoya. So this patient had minimal astigmatism, and we decided that we'll go in for Hoya Impress IOL. So let's see how things went about. So you will see that what I'm going to do is I'm going to create a temporal incision because it gives me the ease, better assess. There is no brow in between. I'm using a bevel up keratome, and I had used, if you could see, the limbus because that gives a faster and a stronger healing. The next part involved is I would like you to see, I'm just, because I see there are so many new people around, how I am putting the visco in the anterior chamber so that there is a visco all around. It is a visco dispersive one. Next part is the, the stepson, which is usually ignored one, is the calibrated side port incision. What do I mean by this? I'm creating an incision, side port incision 500 micron, which calibrates with the side port instruments which I use. I am a fan of doing capsulorhexis with the capsulorhexis forceps. I go through the main incision. My concept is to create a capsulorhexis which should be adequately sized and which should be covering the optics all around. So I'm going around easing myself into a 5.1 millimeter capsulorhexis. The next part is the hydrodissection which I'm doing. I use a 27 gauge cannula for that. You saw the wave, and that was adequate for me because I thought that would be sufficient. Now you just see the parameters which I'm using. The parameters which I'm using is a 28 IOP pressure with the compensation of hardly 2 millimeter when I'm using the 2.8 incision, a 2.8 incision. So once that is there, so I'm using the flow rate is 23. So I'll be doing a modified stop and chop in this patient. So I'm using a balance tip to my advantage. This balance tip gives me the advantage of minimal wound side thermal injury and with an increased stroke length. So I would like you to see the side port calibrated, the chopper which I would be using. You will see that it just snudges in. It gives me adequate, maneuverability also because the difference is around 50 to 100 microns, a different part. So I'll be starting with the sculpting. I do sculpting to realize what type of, nucleus it is, and I found that it was slightly, on the harder side. So I'm going into the valley and and then trying to chop it, which I would be able to. The hold is good. There is no dangling of the nuclear fragment. Once that is done, the next step would be, I would be using the torque. See the place where I place the chopper, and I'll be giving it a rotation. Once that is done, since the chop was not adequate, I'll give it a 180-degree rotation, hold it firmly, and chop it to my advantage. and you will find that it has been chopped fully. So once that part is done, so I've decided now I'm going to chop these foot position 2 again, full thickness, try to separate it. Yes, I've been able to separate it. Rotate it. I'll not emulsify it because I would like that these nuclear fragments should be fully separated. And once they are fully separated, that is the time when I'm going to take them out. You see how I'm doing it, separating them. The vacuum is around 450, the flow rate is around 30, around 28 or so, and the IOP is still around 28 millimeter. Once these nuclear fragments have been totally separated, I'm emulsifying them. I'm bringing the nuclear fragments to, this was a slightly larger fragment, so I totally separated it. I'm not moving my phaco tip left, right, and center. I'm using my fluidics to my advantage. Again, chopping it, separating, and I find, yeah, I'm not able to, so I'll just go in, foot position 2, 3, 2, and then back, and then separating it. I took out the nuclear core because I separated the epinuclear part by pushing it slightly posteriorly. Now I'm using the phaco chopper to my advantage. I'll place it occasionally whenever I am, slightly anterior to protect the corneal endothelium. And here I'm again rotating. Don't go and fish for it because I'm a traditionalist by all means. Total separation. And once the total separation is there, then only I'm going to emulsify it. I'm doing it slightly, the more, harder it is, the more slower I go because I don't want the nuclear fragments to have a chatter and create a situation where, the corneal endothelium gets, endothelial damage is there, last fragment is being taken out. So this is the end of the emulsification. So the pupil size, you will realize, is the same as it was at the start and now at the end of the surgery. This was helpful because there was no undue efflux of fluid from the side port incision. I am a great fan of using a coaxial one. So the coaxial I use is a curved one. The IOP is still the same. And with this IOP, with the bag empty, there is less of, pain which the patient feels. So I go in, the irrigation. So what I do is irrigation off and then I go in. So with this, my indications for using a bimanual is when it's a subluxated cataract, when the capsule is open. So those are I use a by-hand coaxial one to go right for the subincisional one. The IOL which I will be using will be the Hoya one with a multi-cert injector. So that has a 4-in-1 advantage. You can push it, you can rotate it. So this is the one multi-cert injector. This was the one, the Navex which we were using, but now we have a different one, slightly different one, which goes to a sub-2 one. You can push it, or this is the IOL which will be used, a 21.5 diopter IOL. So next is, I'm just trying to refocus it. So you can either push it or rotate it, and the depth management can be done. I use support it with the side port, this thing. There's a depth management with the insert. So it acts as a shield for all types of anterior chamber depths. So this enhanced monofocal is on a Vivinex platform. It's oxygen treated, subsequent to which the amount of opacification, posterior capsular opacification is almost zero. It is glistening free, frosted haptics which help in, no sudden opening up of the haptics which can create a problem occasionally. With this, there is an increased depth of focus. There's a 1.25 diopter defocus which is there. Basically, what they have done is they have played around with the central 2 millimeter zone. There are microscopic changes which are not visible as such. At the end, I just confirm whether the wound is there or not. So the dysphotopsias with this are as good or as bad as a monofocal, so the patient doesn't feel much. In our series of patients which we have used, the add-on which the patients require for the near vision is anything between 1.25 to 1.5 or so. And in these patients, if you do a micro mono, wherein you go hit the first on the myopia and the second side, so there the patients are comfortable with both distance and quite a bit for the near vision. Thank you very much for your kind attention.
Thank you very much, Dr. Rohit, for an excellent presentation. I think any questions for Rohit? I think what he has emphasized, I also personally feel, and I think all the people on the panel would be feeling that this is one of the best injector system that is there. It's really a pleasure and an art to really push it in without any surprises. So ask you or Naren, you would want to
talk,
say? Yeah. You always talk.
The Hoya session, I think we should talk about Hoya lenses, and very important because they have sponsored this, and not because of that, but I'm not flattering, but this is one of the best lenses I have ever seen, and I have gradually, I think the J&J guys are gone out now, I suppose. Gradually, I'm changing over from Hyans to Impress, and I'm very impressed with the Impress lens. It's really fantastic. I think the world's best injector is a multi-cert injector. I think you should all give a big round of applause for Hoya for this wonderful innovation. It goes, I have not had one single calamity with this injector system. It's really fantastic. I don't use Anaga was talking about geometric and geometric plus. I use only geometric for both eyes or geometric plus for both eyes, depending on whatever the patient's requirement is. Both eyes geometric also, the patients are very comfortable, very happy. Their contrast sensitivity is very good, glare halo is very less, and overall it's a very impressive thing. Sharad?
Yeah, I think
some more checks are balanced. I think
no,
you can do it.
See, the problem is I was just going to say with the new pharma rule, for whatever you have said, at best they can give you a gift of 1,000 rupees. So
No, sir, I think.
yeah. So that's the rule. 1,000 rupees de dekte.
Sir, actually.
1,000 rupees and that should not have a tradable value.
Yeah. That rule is not applicable here.
After how many minutes can you repeat it? The 1,000?
No, sir,
Anyway.
actually, in terms of.
No jokes about. I think it's a fantastic injector
no
system. And we go on to the next speaker, Anurag.
So, can I tell a small comment, sir?
Sorry.
Can I tell a.
Yeah.
Yeah, I think if you look at the multi-cert
He's got up to get his
injectors.
1,000 rupees.
If you look at the multi-cert injectors, I think we have to evolve or move towards. I think right now, just because of the financial constraint, I think we have not moved into this kind of a technology because we need to, all our lenses should be a preloaded one. See, because when it is preloaded, you don't manipulate it, you don't damage the lens, less chance of infection, so on and so forth. So I feel eventually the industry will come to a stage where all lenses are preloaded, but the multi-cert is already in that level. And the second thing is the screw. That really will make sure that you don't have those surprises where you have the sudden jerks and the lens just pops out and you have complications. That cannot happen. It's like 100% thing. So that is the beauty of this particular injector, I would say, from my side.
So there are few chairs up front. The only disadvantage, I would say, one, you were talking about the cost, but apart from that, there's only one disadvantage, that if something goes wrong, you can't really put it back into the multi-cert injector because you need a different cartridge. You can't reload a lens. That's the only other advantage, but disadvantage. But I think that is where the industry is moving. Everybody is moving because it's the ease of insertion. But not every company has been able to have this ease of insertion as you are having in the multi-cert. That's what I feel, because there are lenses which get cracked often at times and things like that. But this is one where it has been almost excellent injection technique. Sonu wants to also get his 1,000 rupees.
Sir, scientifically, I feel only those small pupil cases where you exactly want to deliver in the bag, I think that is one very important place where, that long nozzle actually delivers the lens inside the bag. And that has really helped us, in small pupil patients.
So
And-
over to, sorry, you want?
Another point is, with these lenses, they're only going from strength to strength. They started with one of the beautiful injector system, and every lens that got added on the platform is only performing better. So that's the beauty of this, where it's a double winner.
So we have the great guy from Odisha, gin enthusiast, and which is your latest new car that you have bought, a Porsche?
The X5.
X5. Now you should take an X7. Anyway, so I think he's a great surgeon. It's always really a pleasure to talk to Anurag and to see his live surgery. Over to Anurag, please.
Thank you so much, sir. Good afternoon, ladies and gentlemen. As has been stated already, greetings and regards from the land of Lord Jagannath. Now, this was a patient who was pretty young, 45 years old, and unfortunately was one-eyed. He had lost one of his eyes when he was pretty young due to some firecracker injury. He had COVID in 2020 and had been on a course of steroids for a pretty long time. Probably the reason why he started having issues initially with his driving, particularly after sunset in the night time. He kept on ignoring it and neglecting it. Ultimately, he was not able to manage it anymore. And then he came. On evaluation, the patient had only one eye left, so I wanted to give him the best. I so wished that the patient would choose the femto platform, but the patient did not. And as it turns out, as we would find out in the end of this segment, that there was no reason why either me or the patient would regret that decision not to choose femto. The patient was not a suitable candidate for any trifocal or EDOF because his measurements were not pointing towards a perfect suitability. And despite of all the talks, all the discussions we have, I do not think any trifocal or any EDOF is free from the influence of angles. So his angles were high, and I did not choose those IOLs for him. I chose the Vivinex Impress, just like Rohit sir did a few moments back, which is an enhanced monofocal. So as you would probably find out, a lot of these patients, one-eyed patients, initially do not cooperate with you very well when you're trying to align the eye against the coaxial illumination of your microscope. So eventually they do, and it also depends on the type of illumination your microscope projects towards them, if it's very bright or you can manage with a little less illumination. This is the way I make my incisions, both side port and the main port together. And I always zero in on a 2.2 millimeter incision, come what may, the grade of cataract, the type of patient, whatever be the situation. And all three ports are usually made before any solution goes in. So no anchoring of the conjunctiva, and no solution goes in before all the three ports are made. Some amount of preservative-free lignocaine, just to enhance the cooperation from the patient. And then some viscoelastic. 99% of the time, I would just instill HPMC, which is a standard dispersive that we have in our hands, just to keep the economy of the whole thing in the forefront. The capsular excess, again, just like any of us, I would prefer the cystitome first. If it's not permitting me, which happens in a few rare situations, I would revert to the Haldipurkar's forceps. Actually, that's my second go-to instrument if I'm not able to complete it with the cystitome. The excess size in any IOL is important, particularly for these advanced technology IOLs, wherein you want the centration of the optic has to be right at the center. It might not be very circular initially, but we should give our best efforts to make it as full moon and as circular as possible. It's a softish cataract. That's the reason why I wanted to femto it. It is a softish cataract, but the patient did not agree, as I mentioned. The fluidics in my surgeries always remain, it's almost similar. The IOP stays at 20 panel, the aspiration flow rate stays at 23 panel, and the vacuum stays at 450, also panel. This panel mode of selection of vacuum has come in after I got the active century. Before that, I just had a small tail off towards the fag end of the vacuum line. So let's begin with the phaco. In the left hand, I do not have the normal chopper that I would, the Chang's chopper that I normally use. I've substituted that with a much blunter Sinskey hook since the cataract is soft. These sort of nuclei actually cause issues for us. As they say, the softer nuclei are the harder bargains. So if you use PAR in these cases, there's a possibility of a chatter and you might not get a proper hole. So what I'm doing instead is just holding it with vacuum and trying to chop it. And it happens. In majority of the cases, you can vacuum chop or even mechanically chop them, as you would see the secondary chop. So this is the primary chop, which has happened now. And quickly, the secondary chop would also happen. And I'm just keeping the phaco needle right at the point where the nucleus is and trying to levitate. One segment has come up already. We go to the frag mode, and the CDE, as you can see at the top, stands at 0, as we have already started emulsifying the segment. So this is one of the best ways, in fact, my go-to ways for handling very soft cataracts. Do not use PAR at all, because it actually doesn't need it. And as you would see, since this is an unedited video, this doesn't even take too much of time. So after the nucleus, the epinucleus, it's almost forms a complex with it, comes out, and then we go to the cortex. No need to change hands and change instruments. The same phaco needle can do the job. The cortex removal from all around. Of course, you can do that only if you have a proper depth perception coming in from the instrument you're using to visualize. It just does catch the PC at times, but nothing to fret, because if you have control of the foot switch, it doesn't cause anything. So everything's out. Now the bag's ready to receive the implant. Hydro implant is a technique that I choose to implant all my IOLs. Before that, small BSS flush to the PC to remove some of the stub-on fibers that are there. And then finally, I knew that my previous speakers would harp on the injector system of this fantastic assembly, so I did not show that intentionally. I would go straight into the delivery part. This is the hydro delivery, and what I would just add on to whatever was being discussed a while back. Oftentimes, I have not even used viscoelastic in the cartridge. I've just pushed in some visco, and it's so slithery there. Such is the friction that has been lessened in terms of the covers that they have provided on the inner surface of the cartridge, that it moves in without any support of viscoelastic. You don't need any lubrication there. The second instrument, or the aspiration, just goes in to take out one fiber that was there subincisionally, and then the eye is ready to be formed. The CDE still stands at 0. So this is the reason why I said neither I nor did the patient regret that he did not choose the femto. What you achieve with the femto is lessen the phaco energy, and we have not used any phaco energy for this particular patient. After forming the AC, just before, this is particularly true for toric IOL implantations in particular, I believe the surgeon should always watch the speculum being removed, because at that precise moment, there are occasions where the patient squeezes the eye and it egresses some amount of fluid, and the toric IOL particularly shifts its position. So I always watch as the speculum is removed, and the moment it shifts, we will see now the summary of the case. So the overall case time was 3 minutes and 49 seconds. Add to that the rhexis and the incision times. Energy used was 0. There was no ASM, active surge mitigation actuation. So despite of the low fluidics and basically a fluidic based surgery, there was nothing that the machine did to mitigate the potential surge. And the total estimated fluid that we consumed in the process was 23 milliliters. So that's also something that you should keep in mind. So the tissue being safe and fine, the patient being safe and fine, the Vivinex Impress goes in. The next day the patient had, and my experience with the Vivinex Impress thus far has been, I think we have clocked around 100 implants by now. So contrary to what has been told to us by the manufacturers, that it offers a defocus of 0.75, I have found the defocus to be more, consistently so. So I believe that the defocus is somewhere around 1.25. So at 50, it's either N10, that's the worst case scenario, and N8 most often. And almost 90 to 95% of my patients, even after unilateral implants, have achieved an N6 with a +1 add. I think I can count only 2 patients who needed a 1.25. One of them needed a 1.5, but rest all have been N6 with a +1. So the defocus essentially is not. And if you don't have any surface modification at the center, no rings, no photic phenomena, and you're getting a defocus of 1 to 1.25 diopters, I think this is nothing short of just phenomenal. Thank you so much, ladies and gentlemen, for your attention.
Hello. Next we have Dr. Sonu Goyal. He'll be speaking on outstanding rotational stability with textured haptic surface. Dr. Sonu Goyal.
So thanks AIOS, Dr. Namrata Sharma. Thanks Hoya for making me this part of this wonderful concept of deferred leg surgery. So here I'll be showcasing surgery for this 60-year-old teacher, and in fact she's one of the school teachers. She drives, she's fond of reading, and she plays occasional snooker. So actually she wants vision at all three places. So essentially we routinely in our all patients do all these checkups, right from the vision assessments, the keratometry, the power. So power essentially here is 19 with a cylinder of 1.26 minus at 15 degrees. We did the Tracy, the angle alpha, angle kappa less than 0.2, specular 2798, fundus being normal, pressures, and the LipiView, the lipid layer thickness 70. So this is the 700, which essentially gives you the calculation for the cylinder, and this is the specular, and this is the eye trace. We actually look in for all these premium patients for angle alpha and kappa, do a quick LipiView, and all those patients where we find the LLT to be less than 100, we actually subject these patients to a quick warm compressions, azithral, and the treatment for ocular surface. Call these patients 15 days back, do again an IL master, and just see whether the ocular surface is good enough, and then subsequently take these patients for these premium IOL positions. So OCT, yes, subtle lesions can be missed. So actually all of these patients where you are taking these patients premium. So what premium? I mean, for all cataract patients, I think OCT is a must because you tend to miss a lot of these points. So we do the fundus examination, and I think this the wonderful tool with Atlas has given us a overview of the picture. So this is actually what you send these the findings to the Hoya guys. They will give you this picture. So here we are looking at the model of geometry, which is a T2 model plus 19 and to be positioned at 114 degrees. So quick surgery.
Good afternoon. Welcome you all to this wonderful Hoya session. And I'll be showcasing.
So this is we under topical. I take this patient. I do 2 side port 1.1. I use phenocaine because this gives me analgesia as well as pupillary dilatation. Push in viscoelastic HPMC. So I stabilize the globe. Either use a Coughlin's or a McPherson on the left side and try with this 26. So people who are young in training here, I would just always emphasize the role of capsular rhexis, because whenever you're dealing with premium patients, I think a good, well-centered rhexis and appropriate sized rhexis is essential, because that is very important to give you that shrink wrap effect, and that is what actually transforms to a good ELP. Because cataract, whenever you are dealing with these patients, whenever you're doing a 700, whenever you're taking care of the ocular surface, you are basically targeting total emetropic correction post surgery, because that is what essentially gives you that crisp vision what the patient would need for both distance, intermediate, and near. So a quick watch carefully. I go underneath the anterior capsule, push in the fluid wave, and this fluid wave, the stream that you observe is very, very important, because this actually gives you a fair idea that all 360 degrees you have separated the lens from the capsule, and push in a small viscoelastic, and I'm using the Johnson & Johnson Pro here, and the bottle height is 50. So what is more important is that the right hand should always remain stable. I do a straight direct chop, and most of the times it is my left hand which is going to move, and the right hand is just to bury, hold, and the left hand do most of the times the separation laterally. I would try and separate all 360 degrees pieces so that the pieces can be separated, and then gently you can actually emulsify these pieces one by one. So the settings that I would show here are close to the vacuum that I'm using is 400, flow rate of 30, and what is more important is if you see the bottle height, with the Pro system we have actually boiled down from almost a bottle height of 80 to close to 50. Now this gives you a good chamber stability, but at the same time it helps in taking care of the endothelium, and at the same time an appropriate pressure within the anterior chamber, where the compromised nerves in glaucomatous patients is usually spared. So a quick phacoemulsification being done here, and I use bimanual system, and because this gives me a 360-degree separation, gives me a good hold of the globe on either sides, and I'm able to sweep all 360 degrees, and the subincisional cortex is never a problem. The sandblasted system on this also helps me to simultaneously polish the posterior capsule and under surface of the anterior capsule in most of these patients. So quick jet of BSS can actually help in removing those lens fibers on the posterior capsule, and most of these times I would use this sandblasted instrument which has a flow on the top to just snugly sit on the posterior capsule and do away with the fibers, the lens fibers, and just make this surface so shiny so that there is hardly any scope of PCO. And because this is actually what needs to be done in most of these premium patients, so viscoelastic next goes in. The plan is geometry here, and I think the concept of Hoya of getting this concept of a paired approach is this is how the injector system looks like. So this is a T2 model. There are 3 steps to it. People who have not used, so this is the marking. There are 3 markings labeled as 1, 2, 3. The step number 1 is pushing the viscoelastic from this small nozzle here, and this viscoelastic goes and bathes around the implant. The second would be just holding onto the clip and removing this clip, and third would be forwarding the lens so that it gets folded inside the delivery system. So you gradually remove this from the holder, and the beauty of the system, as has been discussed, is both you can have a shooter as well as a screw kind of injector. A point to be highlighted here is the nozzle system here. The length of this nozzle can be adjusted. So most of the times you can have either a combination of a wound assisted system, or if the nozzle you prefer to be long, you can have those lenses getting directly delivered inside the bag. Now that's an actual aid whenever I am dealing with patients with small pupils and patients with when the pupil gets shut down. So actually it gives me a good delivery within the bag. So just watch carefully. I use this and the lens almost goes and delivers inside the bag, and there is hardly any manipulation within the anterior chamber. I'll just like to showcase here the textured haptic with these Hoya lenses. So these are the marking for the toric alignment. The viscoelastic has to be washed very thoroughly and specifically behind the lens. I would just nudge the haptic out of the bag, and I'd like to showcase. So this is how the sandblasted appearance of the Hoya lenses for their toric platform, and this is actually what gives you the additional stability when this lens goes and sits inside the bag and snugly fits within the anterior and the posterior capsule, and this basically bounces or gives you that the rotational stability. So this lens is basically the geometry has a 4-ring segment here. That's the diffractive zone, and beyond it is the refractive zone. So these are the 3 toric alignments, and a combination of geometry and geometric plus. So Hoya has actually played in the lenses with the light distribution. So we have been using Alcon, Restore Plus, or we have been using a mix and match approach, but here the approach has been on the light distribution rather than just 1 minute more on the addition. So the addition, it gives you a near addition of 3.5 and an intermediate of 1.75, but with the geometry it gives you a light distribution of almost 50% for distance, 17 for intermediate, and 20 for near. But if you have a patient, I would always take a patient first on the geometry, try to assess the patient on day 1. If the patient crips for something more than the requirement for near, I would take this patient on the geometric plus, because this gives you a distribution of almost 35% distance and 35% for near. So the patient would be very happy in a combination, and if the patient is quite happy with both distance and intermediate, continue using the geometric in the other eye. So a couple of few patients that we have done, I think the patients have been really very happy with at all the 3 points. So the lens in place, and thank you very much.
Thank you. Before further delay, I would like to invite Dr. Sheetal Brar. She's going to speak on wider range of focus for functional intermediate vision, the IOL to choose.
Just one question to Sonu, what do you think the advantage of this textured haptic surface of this lens?
So I think, sir, this gives you the rotational stability when you're talking of rotations happening in most of the IOL platforms. I think the industry has actually addressed the rotation by making the haptics a little textured, and which actually once the fibrosis happens in the periphery, that gives you that additional the stability, and the lenses are really there where you want actually.
It will be useful for a toric lens platforms much more.
Yeah.
Okay. Thank you, Sonu.
Thank you.
Yeah. Sheetal.
Thank you, sir. Good evening, everyone. So today I'll be talking about the Hoya Impress enhanced monofocal lens and my experience with this particular lens, which now I have been using since almost the past 1 year. So as we have realized the importance of functional intermediate vision, we have also realized that the regular standard monofocal lenses are not enough, and we need something more, basically a lens that provides us a little wider range of focus to enable us to do activities at intermediate distance. So I'm very glad to share the success story of one of my patients whom I recently operated with the Hoya Vivinex Impress enhanced monofocal lens in both her eyes. She is a 63-year-old female. She is a principal of a secondary school, also a social activist by profession, and a palmist by hobby. So on presentation, slit lamp examination showed in the right eye nuclear sclerosis grade 2 cataract, and in the left eye she presented with a mature cataract with vision of just hand movements, and in the right eye she had vision of 6/12. Basically she was managing all her activities only with the right eye, and had a lot of challenges which she will share in the video that I'll be showing at the end of the case. So the visual needs of this patient were identified, and the goals of the surgery were essentially to provide her with functional intermediate vision without any compromise in the quality of vision, so that she is able to see her laptop, mobile, and is also able to sign documents which she had to do being the principal of the school. So I decided to use the Hoya Vivinex Impress enhanced monofocal lens, and this is the biometry sheet of this patient. She has a minimal cylinder of 0.63 diopters in the right eye and 0.68 diopters in the left eye. So this suited for this lens. And also you can see that in the biometry she has a IOL power of plus 23 diopters. So I kind of targeted it for emetropia in both the eyes. So it was plus 23. And this is the surgical video of the left eye, which was recently operated just 5 days ago. And I start my surgery by making a temporal 2.8 millimeter incision, and then injecting some amount of Xylocard and viscoelastic. So as it has already been emphasized many times that we want to have a well-centered capsulorhexis of between 5 to 5.5 millimeters to ensure proper positioning and centration of the lens in the post-op period. So with the Vivinex Impress enhanced monofocal lens, basically these lenses have an optimized aspheric surface of the optic, due to which this lens is tolerant to some amount of decentration as well as tilt. So a decentration of up to 0.7 mm and a tilt of up to 5 degrees can be well tolerated. So I feel that this lens is good for those cases where you expect weakness in the zonules, like pseudoexfoliation, or some amount of zonular weakness due to some other reason. So this is the phaco part. I'm using here the Centurion active fluidic system for phaco emulsification. I've already chopped the nucleus into 2 halves and also done my sub chops to divide the nucleus into 4 to 5 fragments. So this is a relatively soft cataract of grade 2, so easy to separate as well. And this system actually gives us very good chamber stability, very good followability because of the active fluidics. So I'm again chopping these fragments. So very important point for beginners in phaco, try to be in the safe zone, which is the central zone within the capsulorhexis margin. And this is the last piece being emulsified, the last fragment. And you can see that the chamber is very stable. There is no shallowing. So the phacoemulsification part is done. I like to use a coaxial irrigation aspiration system for IA and cortical cleanup. And for the PC polishing, I like to use the hydro polish method. I use a 26 gauge needle and basically a cannula to wash out the visco, the thin fibers which are sticking on the PC. So now I'm using the multi-cert injector from Hoya. My previous speakers have already emphasized on the advantages and benefits of this, and I'm also truly a fan of this injector system. You can see how easy it is to implant the lens, and it does not cause any kind of wound distortion or any kind of problems with the injection of the lens. And the lens goes in a very predictable and smooth manner into the capsular bag without any jerks or any optic or haptic adhesions. So you can see the lens is well centered in the capsular bag. And now I'm evacuating the viscoelastic from behind the IOL as well as in front of the IOL. Now, basically, how this lens helps to achieve enhanced depth of focus is essentially through a proprietary technology, which is incorporated in the central 2 millimeter zone on the optic. So basically, in this zone, they have done a refractive modification, wherein there are microcurvatural changes that lead to changes in the power and variation in the power. So as the incident light hits these tiny peaks and valleys, the light is basically converged in such a manner that it gives you an enhanced depth of focus. So because of this enhanced depth of focus, it also is forgiving to some amount of post-operative refractive surprises as well. So you can see that the lens surface is also very smooth. You cannot appreciate any impression, even an impression of the refractive zone which is there in the center, and it just looks like a regular monofocal lens. And the patients have never complained of any dysphotopsia or any kind of problem with their vision. So this is the post-op day 5 outcomes. Uncorrected patient was 6/6 partial in each eye and was accepting a slight cylinder 0.5 in both the eyes, improving to 6/6. And this is something that I'm seeing very consistently. The near add is for this patient is 1.5, and most of the times in 80% patient it is 1.5. So normally we see it's usually 2.5 or 2.75, but here because it reduces the need for this add, so actually you can assume that it is actually giving you about 1 diopter of additional depth. So this is just, I wanted to show the video, please. Yeah. So this is the patient's experience in her own words, please. It's very fine. Okay. Yeah. Ma'am, let us know something about your lifestyle. What are the kind of activities you like doing on your day-to-day basis?
Ma'am, you see, at the age of 63 years, I am running my own institution, my own school.
Wow.
It is up to 10th level. And besides this, I am the active member of Womanira and Child Welfare Association. That's why I am too much social also.
Very nice.
Yes, before my cataract surgery, there are many challenges in my life. I couldn't recognize the people's face, and they just look like a statue for me. And even I didn't call them their proper name, so I feel embarrassed. Climbing the stairs, it is great difficulty for me. I would afraid I could fall down from the stairs. DHLENCTPALO.
Very good.
This is DNHOBUC.
We are seeing full, okay, with both the eyes. That's 6x6 normal.
Thank you.
Start from this line, ma'am.
Ma'am, HVORK NDVKO
Wow.
BHO BZ.
Amazing. So that is actually 0.1 logmar. Wow.
Okay.
Can you read these lines, ma'am? Just
Thank you.
just 1 minute, sir. Can you see anything in this line?
Yes, ma'am, easily I can read.
Easily. These are very small letters actually.
There is no problem for me, ma'am.
Yeah.
Their parents should take them to parties and other social functions.
Wow. So this is the normal newspaper and magazine print.
Thank you, ma'am.
N8, which you are easily able to read.
Yes, ma'am. Now
So
visual
you
is
will
good.
actually not need reading glasses all the time. Anything here possible?
Okay, Sheetal,
Yes,
I think-
ma'am.
So the patient was very comfortable for here also. Normally we see the patients are able to see N8, but this patient was able to see N6 probably because she ended up having a slight 0.5 cylinder, and she was highly satisfied with the result. And I'm seeing these results very consistently, and this is why when you see these results very repeatedly and consistently, this builds confidence in you as a surgeon, and you can advise these lenses with full confidence to your patients. And this is my experience about these lenses. So thank you so much for your kind
Thank you,
attention.
Sheetal. I think point well taken. All these newer lenses have given us a new life for thinking for us also, and giving back to patient the best outcome possible. I think we would like to thank all the speakers, all the chairpersons for making this session so lively, though it is near live, but it's actually very, very lively. And thank you for a sponsor for this sponsoring a good session. We'd like to have much more such sessions in the AIOS, and anything which can give you some insight, gives you some points to be taken back to you, because you people all are practicing. You may be doing much more surgery than us sitting here. So it is learning from both sides. So whatever interaction we had, let's hope that you have got something out of this, and wish you all the best. Thank you. Sorry for the next session. We took some more time, Tinku Bali and et al.